It's the thing that keeps a lot of people up at night. It erodes your paycheck, it weighs on your employer, and it has totally paralyzed the government. Why did healthcare get to this point in America?
Basically, competition has not been shown to work in healthcare markets because of all the ways that healthcare markets are not like markets for cars or apples. People don't know how to shop. They don't have the information to shop. If you have a heart attack on Nantucket, you can't shop. There's one hospital, you're done. So the notion that competition will solve the problems of the healthcare market is a right-wing talking point, not a plan.
Jon Gruber, the architect of the Affordable Care Act, joins me to talk about how you tackle a hard-to-navigate system and astronomical prices.
What Basic Economics 101 tells you is when a market is broken, it must be regulated. Every other country in the world regulates the prices that are paid for healthcare. We do not. Full stop, that's the answer.
And he talks about why he has seen the political debate weirdly shift.
I think what's happened in the time I've watched is the Democrats have moved to the right and the Republicans have moved further to the right. If you look at the Affordable Care Act, known as, Obamacare, okay, that is actually an incredibly bipartisan piece of legislation. Remember, the individual mandate was thought up by a Republican think tank, implemented by a Republican governor here in Massachusetts.
Welcome to It Turns Out. I'm Kara Miller. Jonathan Gruber is a professor of economics at MIT. He worked in the Clinton administration. He also advised Mitt Romney on healthcare in Massachusetts. And he is, as I mentioned before, an architect of the Affordable Care Act. Most recently, he co-edited the book Long-Term Care Around the World from the University of Chicago Press and the National Bureau of Economic Research. And like all of us, he has watched as the prices for healthcare have just rocketed up. In 2025, a family plan was around about $27,000, which granted, many employers will help their employees with, but somebody's got to cough up the money. And if they're using their money to pay that, that's probably cash that they're not paying you. So in 1970, about 6% of our GDP was spent on healthcare. Now it's closer to 17%. We spend a lot more per person than Japan or than France. We even spend a lot more per person than Switzerland, which spends a lot of money on healthcare. So how did we get here? Gruber says there are three big reasons. The first is we have a very complicated system. There's a lot of paperwork, and you need a lot of administrators to push around that paperwork. The second is we seem to use more healthcare than many other countries. We seem to spend on things that are maybe not medically necessary. But the third and the most important reason, he says, it really comes down to one word: prices.
The famous health economist Uwe Reinhardt wrote an article called "It's the Price is Stupid," paraphrasing the famous quote from the 1992 campaign of "It's the Economy Stupid." And the point is, we just pay massively higher prices for everything in healthcare than other countries do. In Japan, an MRI costs $75. In America, it costs $1,500. Okay? We pay vastly higher prices for our drugs, for our services, for our providers. And that, I think, has become clearly by consensus the major determinant of our higher healthcare costs.
Let me zero in on that MRI example from Japan. $75, I think you said it costs in Japan, $1,500 in the U.S., right?
Let me just say my Japan number may be out of date. The U.S. number is good. The Japan number may be out of date, but even if it's doubled, it's still orders of magnitude lower.
Now, Japan is not like the backwoods or anything. It's it's an industrialized, wealthy country. So would you say that's because, somebody says to you, well, why is this? Is this because doctors are so much richer here? Or is it because, I don't know, health insurance companies are so much bigger? What would you say is going on?
There's a simple answer, Kara, which is that other countries have learned the lesson that Kenneth Arrow taught us in 1963. In the first important research article about health economics, Kenneth Arrow said, the market for healthcare services is fundamentally broken. It does not work as typical economics markets do. all of the failures that economists talk about in markets, like the fact that it's imperfect information or imperfect competition, or all these things we talk about are all present in healthcare. And what Basic Economics 101 tells you is when a market is broken, it must be regulated. Every other country in the world regulates the prices that are paid for healthcare. We do not. Full stop. That's the answer.
Um, let's go back to the question of, is healthcare eating our economy? Another piece of this that I think people don't talk about quite as much as they talk about, oh my gosh, my healthcare bill has gone up a lot. Oh my gosh, my premiums have gone up a lot, is when you look at employment. Healthcare employment has gone up a lot in the last 30 years. It's more than, retail employment in retail has gone down. Employment in manufacturing has gone down, but employment in healthcare has gone way up. I think it might be, you can correct me if I'm wrong, but maybe the single largest employer in the US now. Where does that go?
Well, that's part of it. But I think, and partly we have high employment because we pay high wages for things, and high wages drive people into one of those jobs. We have high employment because we have excess utilization of healthcare, and that drives more jobs. But employment is not necessarily the problem, Kara. In fact, I think a rationalized U.S. healthcare system might feature more employees, not fewer. It would feature employees working. It would feature a system where employees would work at the top of their skill level. And where we would have nurses doing a lot more that high-paid doctors are doing now, and the very highest-paid doctors will make a lot less money.
Okay, so it's not, you're saying the essence of the problem is not that a lot of people work in healthcare, but be specific. How, if you were, changing things around, how might you think about doing that when it comes to this issue of employment and making things more efficient and ideally more cost effective?
First of all, we have to recognize that we get a lot for the money. I want to highlight one thing you didn't mention. Everybody says you didn't do the second half of the claim that's often made, which is, gee, we spend the most and our outcomes are terrible. We're 19th in the world in infant mortality and 15th in the world in life expectancy. Those numbers aren't quite right, but they're approximate. Let me be very clear about that. Those are very misleading statistics. For people like you and I, Kara, the healthcare in America is amazing. It's as good or better than anywhere in the world. The white infant mortality rate in the U.S. is the same as Europe. The black infant mortality rate is lower than Barbados. The problem in the U.S. is healthcare disparities, and that's what drives our bad outcomes. So we really have to separate the healthcare disparities problem, which is really about insurance coverage, from the healthcare spending problem. If you're in the system, you're getting excellent healthcare. We don't want to risk that, but we don't have to. The point is that we can redesign a system where people are getting high quality care. Maybe they're waiting a bit longer to get it for things that are elective, like they do in every other country, but they're still getting high quality care from high quality providers, just at lower regulated prices.
I know this is a big question, but I think, when you sort of zoom out and look at the healthcare landscape in America, one of the curious things is how patchwork it is. So people sometimes think about other countries have government run healthcare and we don't. But that's not quite right? Because if you're a veteran or in the military or you're older or you're poor, you might get government healthcare. Then you've got people who get it through their employer. Then you get people who are paying for it themselves, maybe with some help from the government. Then you have people who have no health care at all. I know this is a big question, but how did we get to this kind of very strange patchwork where, yep, the government covers a bunch of people, but not these people. Employers cover a bunch of people, but not these other people.
Yeah, look, we have a very patchwork system compared to the rest of the world. But let's be clear. I think you really hit a key point there, Kara. People say, oh, we have a private system, the rest of the world is a public system. That's not right at all. The U.S. right now, about half of healthcare spending is public, about half is private. If you look at a typical European country, it's maybe 75-25 or 80-20. It's not, they have a lot of private spending. We have a lot of public spending. It's not that different. The bigger difference is we have many, many, many more moving pieces. They'll have one big national program, and the private will be people buying on their own. So if I want a private room, not a public room, I want to see this specialist, not that specialist. In the US, we have multiple public programs, and we have many, many different private insurers. And so that patchwork nature is really what sort of drives the first of my three elements of higher costs in the U.S., which is administrative costs.
So let me follow up on that, because when you say that 50-50 number, that like half of our spending is public spending on healthcare and half is private, I find that A, fascinating, but B, break that down a little more, because my understanding is that the spending, the public spending is on fewer people. So like the people who get the public spending are in greater need, right?
Not always.
Okay.
The public spending primarily comes through two programs. One is the Medicare program, which is universal coverage for the elderly, many of whom are in great need, but many of whom are not. The other is the Medicaid program, which covers low-income populations, almost all of which are in great need. So it really is mixed. In other countries, programs are much more universal. They cover you sort of regardless of your need. The U.S. has a much more targeted program, but not perfectly. We do have programs like Medicare, which extend to everyone.
So I know you're not in the Trump administration and probably can't read their minds, but if you had to say what their vision is from what you know for healthcare, is the idea sort of let private companies compete for, excluding all these people who get government-run healthcare, like veterans and so on, is it let private companies compete for your dollar? And if so, what's wrong with letting private companies compete for your dollar?
Let's be very clear. Trump and the Republican Party writ large have no vision for healthcare. Okay? They have talking points, which is what you just said, let the private companies pay, but they don't actually have a plan to implement that or any evidence it'll work. Basically, competition has not been shown to work in healthcare markets because of all the ways that healthcare markets are not like markets for cars or apples. People don't know how to shop. They don't have the information to shop. If you have a heart attack on Nantucket, you can't shop. There's one hospital, you're done. So the notion that competition will solve the problems of the healthcare market is a right-wing talking point, not a plan.
Do you feel like in the time, I mean, you worked in the Clinton administration. Do you feel like in the time that you've been watching Republicans and Democrats debate healthcare, that the parties have gotten further apart, or it's just like a standoff and everybody's in trenches and they don't ever move?
Well, no. I mean, I think what's happened in the time I've watched is the Democrats have moved to the right and the Republicans have moved further to the right. If you look at the Affordable Care Act, known as, Obamacare, okay, that is actually an incredibly bipartisan piece of legislation. Remember, the individual mandate was thought up by a Republican think tank, implemented by a Republican governor here in Massachusetts. And the Affordable Care Act, the text was written by a committee of 3 Democrats and 3 Republicans on the Senate Finance Committee before the Tea Party turned Republicans against it. So Democrats moved to the middle to get the compromise we needed to make the most important step forward towards national health insurance in 100 years. The problem is Republicans have just taken that and instead of saying, great, they just moved way more to the right. And as a result, when we talk about, say, repealing and replacing the Affordable Care Act, there is no replace because the replace was the Affordable Care Act. That was the Republican plan. Democrats sort of co-opted it. Speaking of Bill Clinton, in a very sort of Clintonian way, triangulation, sort of said, okay, fine, you've got this good idea, we'll bring it in. And we'll have a compromise that brings in the best of both sides. Republicans reacted not by saying, hey, we got victory, but instead by moving way to the right. And really just the Republican Party essentially, I mean, I realize I'm sounding really partisan, Kara, and I'm sure I get dismissed as that. But honestly, you just look at the data. There are no coherent plans from the Republican Party to significantly either address the number of uninsured or address healthcare costs in this country.
How do you explain that to yourself? Because obviously people who have strokes, car accidents, break limbs, these are not just people in blue states, right? These are all people in all states. So how do you explain to yourself that the parties are so far apart, or as you say, the Republican Party, you feel like has moved very far to the right? They have constituents, and those constituents have medical issues, I assume, sometimes.
Look, it befuddles me as a healthcare economist, but healthcare is just rarely a top voting issue. It's still a big issue, and it's the number one issue on which people vote for Democrats. So voters understand this. Okay, literally, if you line up the issues, healthcare is the number one biggest partisan gap in favor of the Democrats. But it's still not a huge gap. Why not? I mean, honestly, in my view, it should be, 99 to 1. Why isn't it? I think that people, first of all, as our president famously said, healthcare is very complicated. Okay. And I think people are confused by it. It's a very complicated topic. And I think as a result, they tend to just default to their partisan categories and think about other things. They say, yeah, healthcare's hard. I don't know who's going to do a better job. Let me focus on things which are easier to think about, like guns or abortion or immigration. And I think that's why the gap isn't even bigger. But let's be clear, the gap is big. This is the number one partisan issue that favors the Democrats.
You know, one of the things we've seen under President Trump is considerable cuts to Medicaid. Over the summer, the Congressional Budget Office estimated something maybe like 12 million people would be off of Medicaid. One thing I want you to explain to me about that, I think people hear those numbers, they kind of register them. But one thing that's confusing is if I was shopping for something, a necklace or something, and I realized I didn't actually have the money to buy it, I wouldn't buy it. But if I didn't have health care, I assume that I would have the same chance of being in a car accident as I did before I had health care, before when I did have health care, or, you know, I have the same chance of breaking my leg or having a stroke or having a heart attack or whatever. So when people come off of health care, but they're just as likely to have problems as they were when they had health care, how does that work? Explain that to me.
Okay, so a few responses to that. First of all, let's be clear on, because I'm a nerdy academic, let's be clear in terminology. You mean healthcare insurance. Healthcare is the actual care you get. We're talking about health insurance. That's point one. Point two is you're exactly right. People need health insurance. The Medicaid cuts, which have, by the way, not yet taken place. Okay, the first Medicaid cuts take place after next year. Or after in 2027 is when Medicaid starts to get cut. Those cuts will ultimately lead to more than 12 million people losing Medicaid, about 12 million people becoming uninsured. That's on top of, and we don't know how it will resolve, that's on top of the current fight of over about 4 million people lose health insurance because of not extending the ACA subsidies. These are tens of millions of people who will become uninsured. But they'll still need care. What does that mean? That means that they'll still get it if they're in a car accident, but they won't get it if they have other illnesses that just need to be treated. So it will not be the people who use zero healthcare. They'll still use healthcare. That healthcare will be paid for by hospitals who will have to deliver it. Under the law, if someone shows up at the emergency room, you have to treat them, whether they're insured or not. Hospitals deal with that by charging more money to insured people. So ultimately, it's paid by us who are insured. But it's also sure a lot less healthcare will be received. And the best estimates from really well-done studies, in particular studying what the ACA did, are that for about every 800 people lose health insurance, one more person dies. So we are talking tens of thousands of deaths that will occur because people will not get the healthcare they need when they need it.
Now, this question puts some human suffering to the side. But I also wonder what the cost effectiveness is of getting rid of healthcare insurance for so many people. For example, if somebody has a heart condition and they do not take regular medication for it, but they really should, maybe they don't even know they have it because nobody's done the test because they don't have insurance, so they don't go to the doctor. But they end up needing a bypass, which is so much more expensive than taking daily pills. Is it actually cost effective to throw people off insurance, or do they just show up at the emergency room with many more acute problems than they would have?
So here's where we have to get nerdy again. We have to define the difference between cost saving and cost effectiveness. One question is, does it actually cost society money to throw people off insurance? And the answer is no. The answer is, yeah, you avoid people bypasses, but you also spend a lot less on other care people would get. And on net, if people are insured, they spend less on healthcare. People would like to think that there's this magical sort of benefit that if you insure someone, you actually save money. That's not true. If you insure money, they spend more money on healthcare. But cost effective is that money well spent compared to what else the money can be spent on? And there, the answer is yes. The answer is that when people are insured, they are improving your health at a rate which is cost effective. So the idea that somehow society is going to save money by kicking people off health insurance is absolutely right. The idea that it's worth it is wrong. We'll be worse off as a society because all those deaths we're causing are not worth the money we're saving.
You recently co-edited a book, Long-Term Care Around the World. And in it, you point out, I think this is really important as a big picture trend, that the number of people in the US over 65, that number is growing quite rapidly, has gone from 10% to about 20% in the last few decades. And even within that group, the people 85 and older, that's really growing quickly. It seems like people are going to need only more care. So when we talk about healthcare, started talking about healthcare eating the economy. It seems like that's not going to end anytime soon.
Look, here's my favorite fact about this, Kara. If you think about a U.S. state as being old, if more than 1 in 5 people's over 65, today we have 4 states that are old. In 20 years, we'll have 43 states that are old. We're going to be Florida in 20 years.
Wow.
Okay, we're going to be an old nation. That is part of why healthcare costs are destined to rise. That's why I think the notion that we can keep them at 17% or lower them is just false. They're going to rise because we're aging and old people need more healthcare, and that's fine. The question is, but that aging part is not the real concern. The concern is the inflation above and beyond the aging. But it's absolutely true. We're going to spend more on healthcare. We also have a separate issue, which is not just the cost of healthcare for these people, but the cost of actually caring for them, literally getting them fed and housed and toileted and taking care of themselves. That is a separate issue. That's what this book is really focused on. It's not the healthcare cost aspect of it, but the enormous long-term care cost burden. And that's a whole separate and important issue we're going to have to deal with as a society.
So whether you're a Democrat or you're a Republican, or maybe not, maybe nobody will have to grapple with this, but it seems like if you have a society aging as quickly as our society is, and people are going to, people who are over 65 generally need more care than people who are, let's say, under 30. Won't the government have to grapple with some kind of big picture issue if we don't want just healthcare to kind of ruin the economy?
Look, once again, I think the issue is less healthcare ruining the economy. The issue is health. It's really a federal budget issue, not an economy issue. As I said, right now where healthcare is, we can afford it. And indeed, if healthcare goes up a few more percent of GDP, that's not going to crush the economy. It is going to crush the federal deficit. Okay, so if you look at the long run projection for the federal deficit, not where we are now, which is sort of $3 trillion in debt, but the long run, we're more like $75 trillion in debt. Okay, and what is that? That's all rising healthcare spending. 100% of it's rising healthcare spending. That's the biggest problem. The biggest problem is we either society have to cut healthcare or raise more money in taxes, neither of which people want to do. So the action forcing event here is not going to be the economic effects. It's going to be the federal budgetary effects of this rising healthcare costs.
One thing you point out when in writing about long-term care is that, and I did not realize this, when you look at the workforce of people who, like the professionals who take care of people who are older, you go to a nursing home and look at who those people are. A third of those people were not born in America, which is much, much higher than just like, the average person in America who wasn't born in the country. We obviously are dealing with less immigration. How do you see, but increasing need as people get older, how did those two things collide?
They collide. Look, here's the bottom line way to think about it. We are going to have a massive growing need for low-skilled, I don't want to limit by skill, but basically not highly trained people to take care of our elderly, doing jobs which are, quite frankly, can be unpleasant, changing bedpans or toileting or, turning people over in their beds. These are not easy and often not pleasant jobs, and they don't pay well. In Massachusetts, a job like that, something called a certified nurse assistant in a nursing home, pays a little bit better than Starbucks. Okay? So one of 3 things are going to happen. First, we could pay more for those positions. Well, I've already talked about how the federal government's underwater with healthcare. Those dollars are hard to come by. Second of all, we can recognize that there are hundreds of millions of people in other parts of the world who would be delighted to come do those jobs for the wages we're now paying. There's a great deal to be had. Okay, there are people all over the world who are hardworking, talented people who would be happy to come to America, do these difficult jobs so low wages are willing to pay. It's a no-brainer. So basically, the move against immigration is really a move against taking care of our nation's elders. The third is something we're trying to pilot here in Massachusetts, is trying to sort of build better career ladders so we can get more people into the system and then move them up to become nurses. So while the pay is bad at the bottom, you can move them up towards better paying positions at the top. But look, the middle one's the one you asked that, and that's the big one. There's an easy solution here, which is more immigration.
I want to ask you a couple more questions about care. I've written a little bit in the Boston Globe about physicians who, especially in primary care, in emergency medicine, but in other areas too, are increasingly questioning whether they want to be in medicine, or at least in those areas of medicine. And you see a lot of people, moving to other, like working for insurance companies, for example, which employ doctors. And when I've talked to people and said, like, why are you not working in medicine anymore? They talk about billing and coding and just sort of the oppressive nature of doing that. I wonder if you have any concerns about the number of doctors we have and about the kind of disenchantment that we've seen amongst doctors with working within the system.
Sure, I have a lot of concern about that. And that is the challenge with, I talk a big game about regulating healthcare prices. Well, there's the challenge. It's hard to do. And you want to make sure that you don't set prices so low that people don't want to become doctors anymore. I think we're very far from that. I'm sure you can find lots of examples of people who would rather not be a doctor, but there are plenty of people who want to be doctors. Okay, there are not enough people who want to be primary care doctors because they're underpaid relative to specialists, but there are plenty of people who want to become doctors. That's not our problem. We're far from not having enough people. Our problem is that we are having doctors do things they don't have to do. There's still doctors in America that take blood pressure. No doctor should take someone's blood pressure. Nurses should be doing that. Physicians' assistants should be doing that. So we are not using doctors to the top of their abilities. And B, we're not training enough primary care doctors. And then finally, I agree, our fragmented system does lead to a lot of excess demand for things like people working for insurance companies trying to figure out how to manipulate the system to bill people for the highest possible bill so insurance companies can make money. And then doctors end up in those jobs too.
You've also seen, and I don't know if this is a concern or it's just too kind of on the margins for you to worry about, but you've seen a rise in concierge medicine, right? Where people will pay, it could be $2,000 a year, could be $10,000 or $20,000 a year. So this is basically, you have a doctor, you have insurance, you do the normal thing that you would do, you pay for the doctor with the insurance. But on top of that, you might pay like a $5,000 fee so that they see you right away, so that you don't wait in the waiting room. If you get sick, you can get in the next day, which, as anybody who has a doctor knows, is like really, really hard to do. Normally you call up, they say, we can fit you in a year for a physical. I wonder if I think what I worry about in that kind of situation is that, like, the people who make the laws or the people at the top have a completely different experience of medicine than almost everybody else. I don't know if that concerns you.
No, I mean, look, it doesn't concern me for the following reason, Kara, which is, even if you look at the countries everybody points to as, great medical systems, the Scandinavian countries, in all those countries, rich people buy their way out of the system and have better service than poor people. It's just the nature of capitalist economies. The rich people are going to get better stuff, and that includes healthcare. So I'm not concerned about the rise of concierge docs. I think it's just a way that rich people are buying their way out, just like they do in all over the world, regardless of the nature of the system.
Two final questions. First is, if you're being perfectly honest about what you see ahead, when you kind of look ahead, let's say 5 years down the road, assuming things kind of keep going status quo, what happens? How does this story continue to unfold when you think about American healthcare?
So, Kara, first of all, as you know, one of my biggest flaws is I'm always perfectly honest. So let me talk about where I see it going. I basically see us muddling along. I think that, as I said, Republicans have no vision for healthcare. They want to just not talk about it. Democrats have a vision, but honestly, they feel a bit burned by the experience of the Affordable Care Act. That was an important piece of legislation that really sent the Democrats to the wilderness for a decade. Now it's something they can run on, and it's a popular issue. But it was a very tough decade from 2012, 2020. Maybe it got slightly better for 2018. There was a tough period where Democrats lost a lot over their battle of the Affordable Care Act. People have bear those scars. And I think there's not a lot of appetite for bold new initiatives in healthcare, which I think is problematic because, as I said, we'll be fine in 5 years. I'm not worried about 5 years from now. But if we're going to turn this boat, we have to start turning it. I am worried about 50 years from now. And if we're going to really start turning that boat, we got to start turning it soon. It's a bit like global warming. Okay. Is the world going to end in 5 years? No. Will we be in big trouble in 80 years if we don't start dealing with it now? Yes.
You have studied healthcare systems from all over the world for a long time. If you could wave a magic wand and do what you feel like is best for the U.S., what would you do?
My least favorite question, because I like to think of sort of realistic scenarios. But if I could wave a wand for the U.S. and I didn't have to wear political constraints, I think a system which has the flavors of a national regulated health insurance system that provides a basic set of benefits for everyone at regulated prices, along with a system where rich people can buy out, much like the rest of the world features, is the right system. I think that's the right way to go. I just don't know how we get from here to there.
Jon Gruber is a professor of economics at MIT. He helped craft the Affordable Care Act and helped with the Romney administration in Massachusetts and the Clinton administration. He's also the co-editor, most recently, of Long-Term Care Around the World. Jon, always great to talk to you. Thank you so much for your time.
Always good to speak with you, Kara.
Please subscribe to It Turns Out on Apple Podcasts, on Spotify, and on YouTube, where you can like us and you can subscribe to the channel. You can also sign up for our weekly newsletter. That's at itturnsoutShow.com. And I send out a quick newsletter every week to tell you who's coming up and why their research is so compelling. Thanks so much to the Alfred P. Sloan Foundation for their generous support. Thanks to producer Matt Purdy. Thanks to you for watching. Talk to you next time.